Welcome, everyone. Thank you for being here today. Thank you for joining us on a Tuesday afternoon. I hope your lunch isn't making you too sleepy. We are going to wait 2 more minutes, just, a couple more minutes to let some other folks who are trickling in, just a couple minutes late. Sometimes we have tech issues. I know I was running into some earlier. So we're just going to give it another minute or two, and then we'll go ahead and get started. Go ahead and get some tea or some water if you're in cold weather, on dry weather, and we hope you enjoy the next couple hours with us. Okay, just, waiting for a couple of people to trickle in. I'm seeing a lot of familiar faces and names. Welcome back. So let's go ahead and get started. Welcome to our first town hall of this year, 2022. Can't believe it's been, a couple of years since we've all been in this, worldwide situation together. And so today we're going to be talking about navigating mental health insurances, top 10 ways to get your mental health insurance claims paid. And it's going to be presented by our Kantor speakers, Elizabeth Green and Carrie Schwartz. I'm sorry, I didn't check in the names before. But I hope I pronounced it correctly. Let's go ahead and go on to the next slide. So before we begin, and for those folks who have been in this town hall, for our virtual town hall events before last year, very similar concept that today our event's being recorded. Everyone's going to be in listen-only mode, and we're going to be using the chat box to answer questions and have comments. The chat box is open to everyone, so you're welcome to also provide resources to each other. We love when a community comes together and is able to use their own expertise and help out each other. We will save questions and answer all the questions towards more the end of the presentation, just so that everyone is able to hear the answers. And then we will also have a link for our activity session. We have like an interactive what's it called, polling called Mentimeter. And for the folks who have been here before, some of you used it. You're also welcome to use the chat to participate as well, but Mentee is a really fun way to see some of your responses live visually, and you'll see that soon. Let's go ahead and go to the next slide. We also want to go over community agreements. One of the biggest important parts of, talking about mental health and behavioral health is just creating a safe space for everyone. And reducing stigma and accepting people's diversity. So we want to be curious and open and respectful to each other. We learn from each other. We want to share the space, and we want to speak from our own experiences, such as using I statements. We want to accept and be sensitive to diversity, and then learning leaves the names day, as in we'll learn a lot of information today, learn from each other, but some people might share something that's personal to them. So we just want to make sure we honor people's, right to be here today. And then we also want to take care of ourselves. Some of the topics that we talk about and some things that might be mentioned might be some types of emotional, be emotionally charging. So please feel free to take care of yourself, step away, or even leave and, speak to us afterwards. And you have the right to change your mind, so you don't have to stay the entire time. We want to be respectful of your time. Next slide. So welcome, everyone. My name is Ragni Law. I'm the Director of Workforce and Community Engagement. I also have my wonderful team, Ashlyn Haskins, who's, put this, coordinated and produced this all together, and then Kim as well. And then I also want to go ahead and say thank you to Elizabeth and Carrie for being here today from Kantor. And then thank you all for also being here today. Go ahead. So as I was talking about the polling, and a great way to be interactive is to go to mentee.com and use the code 1485 4484. Sorry, Ashlyn, I think you got the wrong code in. So one on the top. So the fun thing about Mentee is that every couple hours the code changes until you really start presenting. So sometimes we sometimes get the code wrong, but I'm gonna go ahead and put it in this time, but we're gonna test it out real soon to see if the code works. There we go. Thank you so much, Ashlyn. So how to participate is that you can just open up another tab or go on your phone on, your internet browser and just type in www.mentee.com, MENTI.com, and then you can use the code 14854484. We just put that into chat as well. Yeah, so let's go into the next slide. This is a visual of how you can use Mentee if you choose to use your phone. And then here's our first question for today. So we all want to know kind of where everyone's from, how everyone's feeling today, and just get to know you a little bit more. So what county are you joining us from? You can either, again, use Mentee or on chat. Hopefully they start populating. Sometimes we have tech lags. Got Ventura, Riverside, Glendale. Lots of Ventura folks, Los Angeles, Santa Clara, Orange County. Do you want to click on the arrow, the white arrow? Is it not coming forward? There we go. San Mateo, Santa Cruz, Sonoma, USA. Los Angeles. Welcome, everyone. Sacramento. Shout out to Sacramento folks. Kern County. Okay. Well, welcome. So glad to see that we have such a diverse, group of folks from all over California, San Joaquin, San Bernardino. Awesome. And maybe someone from outside of California. That's fine too. Next slide. So next thing that we always usually ask, or also kind of want to get to know you more about, is how you identify your role or how you identify yourself out of these options. We have plenty of options from family member, parent, caregiver to consumer peer. You can be a NAMI affiliate or another community-based organization. You can be a licensed mental health provider, county representative, county behavioral health director. You can be a student, a clinician, or others, or, if you don't want to answer, that's totally fine as well. This is all very optional. Polling is also optional. And if you're more than one, I'm not sure if we had the slide so you can pick more than one. If you are more than one and aren't able to pick that, please feel free to put that into chat. Caregiver, spouse, conservator. That's what we're hearing on the chat. Is their parents, public health nurses, family member, parent, caregiver. Looks like we have a lot of family members. Then the next top we're seeing is consumer peers and NAMI affiliates and CBOs. I wonder what those folks who are others are. Please feel free to put that into chat. Okay. Well, thank you all for responding. I really appreciate your interactiveness, and I would like to go ahead and hand it over to Elizabeth and Carrie regarding mental health insurance. Thank you.
Thanks, Ragini. Hi, everyone. My name is Elizabeth Green, and I'm so happy to be here with my colleague, Carrie Schwartz, and we are going to try to navigate mental health insurance. And we've come up with sort of what we think of our top 10 ways to help you get your mental health insurance claims paid. We do this for a living. We're attorneys, and our goal today is to help educate patients, families, providers about health insurance policies and how to get the most out of them. And want to give you some hands-on information from what we've learned in our practice that you can use and really empower you, because more than anything, knowledge is power in this arena, and you usually don't need to know it until you need to know it. But maybe you can learn something today you can take and apply for yourself or someone that you care about. And hopefully we can answer some specific questions you might have too. We want to make sure we save time for that. So Carrie's going to take a little bit through who we are here.
Good afternoon, everyone. Thank you so much for taking the time out of your busy schedules to join us. Our office is based in Northridge, California, but we have 20 attorneys that are all over the country, but primarily based in Los Angeles and the San Francisco Bay Area, also in Nevada, Oregon, and Washington. As has been mentioned before, we are attorneys, so we do work in a law firm. And our law firm is a contingency-based law firm, which means that we only get paid on the cases we take if we're successful in obtaining a settlement, a monetary settlement for our clients. We don't take retainers and fees up front from our clients. Our firm handles a wide variety of issues surrounding employee benefits, which is a very large umbrella, but encompasses health insurance claims, life insurance claims, disability insurance claims, and pension claims. We handle appeals and litigation nationwide. We have a very strong network of colleagues who work with us in other states when we need to file cases. For example, in Florida or Texas or New York. We are primarily known as the only law firm in the nation that focuses on mental illness and eating disorders. And there's a reason for that, and that's because we've been involved in cases that have set precedent across the country for the treatment of patients with eating disorders and mental illnesses. So we're very proud of the reputation that we've garnered and earned in probably what's close to 2 decades of work that started with one of our founding partners, Lisa Kantor. We provided you with information regarding our website, so you know where to find us, and other information. We have blogs, we have articles, we have resources. And it's important to know how to reach us individually as well. So we have included our individual email addresses here, and we will provide them again at the end. We hope that the information we share will show you some of the things that we believe will help navigate the health insurance claims process. We have our experience handling administrative appeals and litigation with when health claims are denied. And so we're very excited to be here today, Elizabeth and I, because this is our focus. This is what we do every day. And we love opportunities like this where we get to give back and share information and practical tips that you can actually walk away from this presentation with and feel like you've been empowered and educated with some really important knowledge that may benefit you or a family member or someone else that you know in the community.
So here's an overview of the sort of how we categorized it today, the 10 things we wanted to focus on. The first is where we start with every single person that we talk to, which is what kind of health insurance do you have? And is it ERISA? And if you're not familiar with the acronym ERISA, you will be, and you'll be able to tell someone else about it in about 5 minutes. And it does matter a whole lot. Second, what are the key provisions in health plans that could result in a denial? What are the things that you might want to hone in on when you get a copy of your plan? Because they're long, they're at least 50 pages. It's a lot of information that you may not need in there, but for mental health claims in particular, there are certain things that I think you really want to jump to and see if it will affect the benefits at issue. In and out of network benefits, this is a bit of a tricky one that gets people tripped up, we find. So we want to just go over that and let you know what we think of, what happens when you go in or out of network. how that can affect what benefits you could get under your plan. The levels of care for mental health treatment. I'm sure that a lot of people listening could probably tell us what these are, but it's really important to know what those are if you're not familiar, to understand when you're seeking a claim for benefits, exactly what we're talking about, what kind of treatment is being sought. And submitting timely claims. What does that look like? It's not always something that a provider does. I think it's really good for people we talk to know that they can submit claims and what that looks like and how that process works.
We're also going to talk about explanations of benefits, often referred to as EOBs, and make sure that everyone understands that an EOB is in fact a type of denial. Denials don't always come in the form of a traditional letter. We want to talk about, excuse me, how to submit quality appeals and what that looks like, and give you some practical tips and advice, because as Elizabeth said, might not always be the provider who's submitting the claims or following up and doing the appeals. We also have some tips and things that we think everyone should be aware of when communicating with the insurance company. And we want to address medical necessity guidelines, what they are, who makes them up, and how do we know where to find them. And then lastly, we're going to conclude with some discussion about recent developments in case law that has to do particularly with mental health benefits, so that everyone can be aware of some of what's been happening.
So we'll start with a question to kick us off here, a poll question. Just how familiar is everyone with ERISA, or simply what we say not ERISA? So we have like an ERISA bucket and a not ERISA. So if you know of it, you've heard of what ERISA means, or you've heard that the phrase, but you just don't know what it means, there's a choice for that. You know a little bit about it, not a whole lot, or it's like brand new to you. So almost a tie for it's new to people versus they've heard of it but don't know quite what it means. I have to say from personal experience, I did not know what ERISA meant when I came out of law school. This was a new field for me, and I've been doing this for almost 20 years now. And it's a very important thing, I think, for everybody to know, because it's a lot of how people get their benefits. Okay, so let's get into it. Excuse me. Here we go. ERISA and then non-ERISA, just everything else. And I should say at this point, everything else, non-ERISA, would technically include Medicare and MediCal. We are not lawyers who work in Medicare and MediCal. It's sort of a whole separate universe of procedures and appeals and regulations. So what we're talking about is not just is everything but Medicare and MediCal. We do a lot of all sorts of other policies and benefit plans, but not those two. So I just want to put that up front because we usually have a couple questions about that.
I'll just also add to that, we also don't do TRICARE, which not as often, but every once in a while someone will ask us about TRICARE, and that's also something that we do not handle.
Right. And we'll throw a joke at you to start. Laughter is the best medicine, but your insurance only covers chuckles, snickers, and giggles, because we have to laugh because a lot of times we see things that are just so ridiculous you can't even believe that it's happening. Okay, so ERISA stands for the Employment Retirement Income Security Act of 1974. It goes by the acronym ERISA. We often have to remind ourselves that it's the employee, not the employer, but the Employee Retirement Income Security Act. This is meant that it's for the employees, it's for the people who are participating in it, not the Insurance Companies Act, and it's not the Employers Act. It was initially created for pension benefits because a lot of people got pension benefits through their employers, and Congress created a way to regulate how that looks, make sure that that was being regulated honorably and by the employers correctly, fairly to everyone. That's what I'm trying to say. And then it eventually has evolved into disability benefits, life benefits, health benefits. If you've worked for a large employer, you've probably gotten some benefit package that includes some of these benefits. It may just be health benefits, but it could include life insurance or disability benefits, or maybe pension still. ERISA is really important because it sets the regulations as to how plans have to provide benefits to the participants, what kind of review it needs to be. It needs to be a full and fair review, what the appeals need to be looked at, what that process is, the right to sue under ERISA. This is just like a very broad generalization, but there are a whole litany of procedures, but they're generally all developed to make sure that benefits are being given fairly to the participants. They can be insured, meaning that there is an ERISA plan that has an insurance policy behind it. Say Anthem Blue Cross insures the policy. There's, if payments need to be made, it's made through that insurance policy. Or what we see a lot in health plans is that they're self-funded, meaning that the employer says, you know what, we're not going to do insurance. We have so many participants. We're such a big employer. We have the funds. We're just going to pay through it through our own funds or a trust that we're going to set up to pay for the benefits. So that's often how it works. Sometimes there's confusion as to whether if a plan is self-funded by the employer, it still falls under ERISA. It does. ERISA just means that your benefits came through your employer, okay? So just remember that. When you hear ERISA, just think employer. My employer gave me these benefits. What it doesn't do, it doesn't apply to government or religious employers. So if you work for a school district, a public school district, or if you work for a religious institution, then it will not apply to you. Those are exceptions. It is a streamlined process. ERISA provides for a very streamlined administrative process to try to handle these benefits. And because of that, it doesn't provide for a jury trial or state court litigation. It's a federal act, so it has to be filed in federal court, and a federal judge will decide whether the benefits are owed or not. And it doesn't allow for extra damages. So when ERISA was created, Congress and courts since then have decided, you know, we don't want to punish employers too much for denying benefits. We just want to put people back where they should have been. So if you're denied benefits, if you have to file a lawsuit for ERISA benefits, what you would be able to get at the end of the day, if all things go well, are just the benefits you were entitled to under the plan and any attorney's fees or costs that you incurred trying to get those benefits. It's just meant to put you back where you should have started from with the benefits being paid, but it doesn't provide for punitive damages or emotional distress or financial distress. This is a tough one because insurance companies or employer plans may cause a lot of problems that if it were a different type of plan, there would be an option for punitive damages or financial distress if you're strapped for finances because of what happens when the plan denied benefits. But ERISA just doesn't apply for that. It does apply, I'm looking at the right-hand side now of the screen, it does apply to all sorts of other employers regardless of size. It does allow employees to sue in federal court if the requisite number of appeals are done, and that's determined by what's in the plan. They can require up to 2 appeals. It may be that only 1 appeal is required, but it can be up to 2. It can't require more than 2. And it allows the damage that I talked about to be awarded in court, which are the benefits that should have been paid. We can ask for a little interest on those benefits and attorney's fees and costs. And I said that the regulations are extensive, and they are, and this is just an overview, but generally it's intended to help the claimants in the following ways. Everything needs to be in writing. If you get a denial, it needs to be for treatment or a claim of some sort. It must be provided to you in writing. And emails, that kind of thing is not what they're talking about. It needs to be provided in a letter. that's mailed to you or an explanation of benefits, something like that. And as Carrie mentioned, a denial could be in an explanation of benefits. We'll go over that a little more. Traditionally, you see them in a letter format. It comes, it says, we've gotten this request and we're denying it for this reason. It can require, as I said, up to 2 appeals. There are the right to external reviews, and you can choose to do more appeals or reviews if you like under the plan. It's just that ERISA doesn't necessarily require more. It does provide the time frame of the appeal. So your plan can't require the first appeal to be due any sooner than 180 days from when you got the denial. So there's a nice block of time, 180 days. We've got 6 months to do your appeal. It can't be any sooner than that. It can be later. A lot of Cigna policies are 365 days, but it can't be any sooner. And the second appeal, if it's offered, it can be much shorter. So some of these are only 60 days. That's a real quick turnaround. So, and with the mail, the way it is these days, I mean, we're getting letters that are dated like weeks after they're sent. So we're trying to be really diligent about what these deadlines look like. And if there are any providers listening, there may be a couple, but often providers may do an urgent or expedited appeal, especially if this is a really high level of care that's being sought. Those have to be decided much sooner. Those are within 72 hours. And then another interesting bit of regulation that ERISA provides is that a concurrent care request, these would be requests that are happening when someone is in a long treatment, say a residential treatment of some sort, or a partial hospitalization, or even an inpatient hospitalization. If they're in a continuance concurrent, we call a care, then those must be decided before their approval period runs out. So say benefits are provided through a Friday, they need to make a decision on Saturday before the Friday runs out. So it's just a timing issue. It's not always, it doesn't always happen with the insurance companies, but that's how it's supposed to happen, that you know before the approval period runs out whether your benefits have been extended or not. And this is what, in the perfect scenario, this is what a denial is supposed to have. It's supposed to be specific. It's not just supposed to say, you don't meet our medical necessity guidelines and we're denying benefits. It's supposed to be specific. What is it that they're saying wasn't met? They're supposed to, meaning they, the plan, the administrator, or the insurance company is communicating, needs to describe what information is needed to perfect the claim. This phrase, to perfect the claim, is really important. So if, say they're saying, we just don't see it. There's no need for this treatment. They need to say what information would they need to make it so that you've perfected your claim and you've given them everything you possibly have. If there's something else that's out there and the administrator knows about it, they need to explain to you what that is and request it from you. They need to give you where to send the appeal. This is really important. This might be different than what's in the plan. We'll talk about that, but knowing where to send the appeal is really important. They're supposed to provide, either give you the guidelines that they use to make any medical necessity determination, or offer to provide them free of charge. They almost never provide them with the denial letter. They just don't do it. They don't give you guidelines. They may give you a link to find them online, but they're not giving you the guidelines. And getting them free of charge, it's supposed to happen. It's also a little tricky because sometimes they use proprietary guidelines and they pay for those and they're not free to the public. And so I've really run into this in some cases where my clients have said, please give us these guidelines, and they can't get a copy. That doesn't comply with ERISA. And just like they're supposed to give a specific reason for denial, they must explain their medical necessity determination. What is it that they deem not medically necessary? With an appeal, it's interesting, they have to not defer to the original decision. So the second decision on an appeal is supposed to look at it independent and not just say, well, this, other person decided to deny it, so I'm just going to rubber stamp that. It needs to be a whole other look to it. It needs to be a different person who decides the appeal. And if it is a medical necessity denial, then the insurance company or administrator needs to consult with a healthcare professional with appropriate training and experience. This has been litigated. What does it mean to have appropriate training and experience? We do, as Carrie said, a lot of cases for patients who have eating disorders. Is it sufficient for a healthcare professional to be a psychiatrist but not have any experience treating patients with eating disorders? Is that person appropriate to be reviewing a request for treatment of an eating disorder? We would say no. It can be a nurse. When it says healthcare professional, it's for a reason. It doesn't say physician. It could be a nurse. As I said, could be a psychiatrist who doesn't have the experience of treating patients with that specific condition. And I've gotten into this before, taking depositions of doctors. There was a doctor I deposed years ago who had worked in a men's prison in California. And I asked him if he had seen any patients with eating disorders at the men's prison. And he equivocated and said, well, sometimes the prisoners would go on a hunger strike. And is that an eating disorder? He said, I don't know, maybe. So I don't find that his qualifications really fit the bill for what was needed in the case that he was reviewing. But just to give you an example of what we see. That's okay. And then we have the NonOrisa Plans, which Carrie will walk you through.
So this is a little more straightforward. So you can maybe breathe a little sigh of relief. As Elizabeth said earlier, when we talk about NonOrisa plans, we're talking about a plan that could have come from a government or religious employer. And again, best examples of that are individuals who work for school districts or a church or temple, or, and this is a big or, a NonOrisa plan is an insurance policy that was purchased privately through an insurance agent or through an exchange, and you, the insured, are paying the entire premium. And this could be an individual plan or policy. It could also be a family plan or policy that you purchase for the benefit of everyone in your family who's a dependent. If this is the case, if you have one of these NonOrisa plans, then you can either get a copy of it from your insurance company if you purchased it on your own, or you can request a copy from your employer if you work for a government agency or a religious employer. And that is where you can get that. Oftentimes, I also find that individuals who have these types of policies, more predominantly the insurance policies that were purchased privately, have access to an online portal, and it's often available. The policy is available for download in your individual portal because it's linked to your account, and it provides you with a copy of the current and most recent and up-to-date policy with any amendments or addendums that have been issued for that policy. Some of the distinguishing features here when we're talking about NonOrisa plans are that NonOrisa plans allow you to have a jury trial. These cases are filed in state court, not federal court. Evidence that is outside the administrative record can be used. So for example, in NonOrisa cases, it's quite common for us to prepare individuals to testify and provide testimony at a hearing. And that could be a treating doctor. It could be an outside expert who we might retain to give an opinion on the individual's diagnosis and the treatment that was received. It could be the individual themselves who received the treatment, or a family member if we feel they have something that they can offer to assist us in proving our case. In these NonOrisa cases, there can be additional remedies for emotional distress. There can be additional benefits for attorney's fees and punitive damages. But this is all done or evaluated on a case-by-case basis, depending on the state law where we're filing the lawsuit and where the litigation takes place, and whether the plan, if it's from an employer, was insured. And in some states, we have to look to see whether the laws provide for bad faith remedies. So again, it's a case-by-case evaluation to see where we're filing and what specific remedies are available in those specific jurisdictions. So to sum it all up and bring it all back into perspective, we just wanted to highlight again a little comparison of the ERISA and non-ERISA plans, because as Elizabeth said at the very beginning of this section of the presentation, the very first question we ask anyone who reaches out to us with an inquiry or question is, what type of plan do you have? So again, if you have a plan that was obtained from an employer that is not a government entity or a religious organization, then you have an ERISA plan. If you have a plan or policy that was issued from a government or religious employer or was purchased individually, then you have a non-ERISA plan. If you need a copy of your plan and you have an ERISA plan, then you can go to your Human Resources Department through your employer and request a copy of it. If you have a non-ERISA plan, you can ask your insurance company or your employer. Or as I said, another way of quote unquote asking your insurance company is going on their website or your individual patient portal to access a copy of the plan or the policy. Under ERISA, there are no jury trials. All cases are decided by a federal judge, whereas a non-ERISA plan, if we pursue litigation, there will be a jury trial. For ERISA plans, there are no punitive damages. And for non-ERISA plans, there may be punitive damages, but that depends on the state law and whether or not the benefits were insured, which means they were not self-funded. So this is where we do an in-depth evaluation of a case to look at the plan or the policy and the state in which the case would have to be filed. And as far as trial goes, when you're dealing with an ERISA plan, any trial, which is called a bench trial because it's run by the federal judge, is limited to the documents that were generated during the claims and appeals process, which is what is referred to as the administrative record. And that is the group of documents that the judge will be relying on in making his or her decision. And nothing outside the scope of the administrative record is permissible for the purposes of deciding that case. And for a non-ERISA plan, we do not have that same constraint. We can introduce witness testimony, we can introduce expert testimony, and we can use documents that are outside of any record that was produced.
Okay, so if there's one takeaway from today that we'd love you to remember is getting a copy of your benefit plan. So by show of hands here, let's see, by polling, you have a copy of your benefit plan, you don't have a copy, what was the third option? Not showing, or I guess maybe it's just the two. So please vote. Let us know if you have a copy of your benefit plan and you've perused it, or you don't have one, but you are interested in learning more. Okay, small polling section here, but we'll move on. So, now we don't, more people now don't have a copy. Even, this is fun, okay. So the next point we're going to talk about has to do with what's in your benefit plan. So this is what I mentioned before, what to look for in your benefit plan, specifically for mental health benefits. You'll find a whole lot of information about very specific things in there, but if you have a claim for mental health benefits, if you're looking to see what your coverage provides, these are things that we've pulled out as kind of your go-tos. And as the comic says on the side, prior authorization can really trip people up. Pre-certification, pre-authorization, depending on what kind of plan you have, there's a whole range of language in the plan about what happens if you don't get a pre-certification or pre-authorization, or even if the plan requires it. Carrie will talk a little bit about what an out-of-network provider looks like, an HMO perhaps, and there's some plans that say you can't go out of our network, so don't bother pre-authorizing or asking for pre-certification for an out-of-network benefit. But traditionally what we see is something like a penalty of $1 amount for not calling ahead of time for treatment. Or the penalty could be that they can deny the whole claim. The language, if it's vague language, unfortunately, sometimes courts will say that, well, you didn't get this pre-certified, so no benefit. Now, the one caveat to this is it really just requires you to call. They can still say no. It's not that they're going to necessarily authorize, but it should be really phrased more as pre-notification, that you're notifying them ahead of time. I'm looking to get this treatment, and it's required under the plan that I let you know ahead of time. So I'm calling or writing and asking that you pre-certify or pre-authorize it. The proof of loss, this phrase means basically when you have to submit your claim. What's the deadline? If you're doing this yourself, then you really want to know if the deadline is 6 months, if it's a year. Those are generally kind of the two time periods we see, but you really want to know what your deadlines are to submit claims. The statute of limitations is the deadline to file a lawsuit. This is something, of course, Carrie and I are always looking at, because it can really prevent someone from moving forward if they're pushing up against their statute of limitations or if they've missed it. It really, and it can also tell you what needs to be done before you file a lawsuit. If you have to complete the appeals that are listed above before you file a lawsuit, you need to know that. And going into the number of appeals, your plan will tell you how many appeals you have to complete. I talked about this about ERISA. You don't have to complete more than 2. It has to be probably at least 1. But you need to know when those appeals are due and where to send them and how many there are. And the plan will tell you that. Other items to look for, other provisions to look for specific to mental health benefits. Residential treatment center definition. This runs the gamut. I mean, there can be no definition of residential treatment, or there can be such an extensive definition that no one could possibly comply with it because there's no treatment center that meets every single one of those items. But the definition could include things like requiring a physician to be on staff, or what kind of physician needs to be on staff, the licensing requirements for that state that need to be met, or the residential treatment definition could exclude certain types of treatment, like a wilderness treatment program. And I'll go through this in our legal developments, but the exclusion, a flat out exclusion for residential treatment, is really not permitted anywhere. It would take a really specific policy that's grandfathered and lots of things to happen for it to be valid. But with federal mental health parity laws, they are really not enforceable at all anymore, particularly in California, because we also have a California Mental Health Parity Act that applies in addition to the federal act. The other language that's really important for mental health benefits is the definition of medical necessity or medically necessary. This is the most common kind of denial that we see. Someone is denied mental health benefits because the insurance company finds that it's not medically necessary. And so we want to know, well, what is it in the plan that just, what language there tells us as to what is medically necessary? And it usually says something like the treatment needs to comply with generally accepted standards of medical care. We often use the American Psychiatric Association guidelines. There's very specific APA guidelines that apply for different types of conditions. like eating disorders. And so those are usually our go-to as to what is generally accepted within the medical community. So our homework for you, if you want to get ahead of the game, get a copy of your plan so that you know what's covered and ask for it in writing. That's the best way to make sure that somebody got it. Sending an email or asking over the phone can be easily ignored, but asking for it in writing, just writing a letter to whoever at your HR department or the insurance company themselves, asking for the plan. It actually is something that we often do in the office because ERISA policies and plans that I work with my clients, there is actually a provision in the law that provides that if you ask for the plan, you ask for your ERISA plan and you don't receive it, there's a penalty that can apply, that the court can apply, and it's $110 a day for every day you don't get the plan. So there is a bit of a, penalty or incentive, however you want to look at it, for the employer to make sure that they get back to you with your plan. But asking for it in writing is the best way to make sure you get that.
So I want to talk about in-network providers and out-of-network providers, because often there's some confusion and questions, and this can be tricky to navigate. There's different terminology that's used. Some people say in-network providers, some people say participating providers, some people use out-of-network providers, some people say non-participating providers. It's important to know what you're dealing with because reimbursement is going to be different and how your insurance company processes these claims is going to be different. So what happens when you realize that there's no in-network provider in your area or with the specialization or type of treatment that can provide the type of treatment or the level of care that you need or a family member needs? What do you do when you're in that situation? And I think many of us have experienced that or know someone who's experienced that. I mean, the alarming statistics that you read about even before the pandemic, which have only been highlighted by the pandemic, suggest that as a country, we don't have enough mental health providers for adults and for children, and it's a very large problem. So what can you do, or what can you tell someone to do who's in this situation? We always tell people to ask for a single case agreement, which is sometimes referred to as an SCA or a gap exception. And this allows for an out-of-network provider to be considered an in-network provider, but it's for the purposes of treatment with that particular provider only. And oftentimes, in my experience, the insurance company will only approve it either for a certain number of sessions or what they might refer to as units of treatment, or for a specific period of time. So hypothetically, you might go to Anthem and say, I need to ask for a single case agreement to have my son treat with this outpatient provider. And Anthem will ask you questions and gather information and details from you as to why you feel you need that single case agreement. And then they get to decide if they're going to approve it or deny it. And I've seen cases where they've approved it and it is specifically limited to a 365-day period of time. So any treatment received from that specific provider during that 365-day period will be covered at an in-network rate, even though the provider would otherwise be considered an out-of-network provider. But the key here is that you have to discuss it with a provider so that they're willing to and agreeable to the rate that will be provided and issued by the insurance company, and also that you request this prior to treatment. It is highly unlikely that an insurance company will retroactively authorize out-of-network treatment. And sometimes people say, but it's just a preference. I don't like this provider, but I like this provider, and they're not in network. Unfortunately, that's not enough to convince the insurance company. You have to show lack of availability of a in-network provider within 50 miles of your home, or a provider who has the specialization that's required that is not offered in network. And we often refer to these types of issues as network adequacy issues or ghost networks, where the insurance company might claim to have in-network providers, but in actuality, when you do the research and you start calling around to the people that they quote unquote have on their list who are available, you begin to realize that they're not available. So this raises the issue of balance billing, something that a lot of people get very confused about. Some states have enacted laws to protect patients from balance billing, which is when an out-of-network physician, it is when you receive billing from an out-of-network physician at an in-network facility, which happens all the time. We see this every single day where individuals think that because they're going to an in-network facility, all of their treatment will be covered. But in fact, at that facility, there might be other providers who are working who are not in network. As a patient, if you haven't signed a financial responsibility agreement, an in-network provider cannot charge you for denied dates of service. So we always ask individuals to provide us a copy of any financial responsibility agreements, any financial documents that they signed at admission or close to admission or at the time of denial. It also depends on the contract between the provider and the insurer. So in some cases, we have to really examine and ask the provider to tell us or show us what is in their provider contract with Blue Shield or Anthem or Cigna, so that we can see what the contract states with regards to balance billing. HMOs are an interesting topic because, and I know someone in the chat already asked. When we think about HMOs, I think for us, Elizabeth and myself, first thing that always comes to mind is Kaiser. And it's important to understand that an HMO have their own networks of doctors, hospitals, and other providers who have agreed to provide services and accept a particular payment. And that payment will encompass all types of services that that provider offers. Why are there HMOs, or what's the benefit? Well, from an HMO standpoint, from the insurance standpoint, it allows them to keep their costs down, and it allows them to kind of keep tabs on their members, because you have to have a PCP, a primary care physician, who acts as the gatekeeper for all of your treatment. So if you participate in an HMO and you want to receive mental health counseling or a referral to a psychiatric doctor for medication management, that all has to be delegated and through your PCP, who gets to basically decide when referrals to specialists are appropriate. And then they get to provide you with that referral. It's not the same as an authorization, however. Those are different processes, and sometimes people get confused between the referral process and the authorization process. And if you are someone who has an HMO, it's very, very important that you pay attention to the terms in your policy regarding referrals and authorization for treatment, because referrals are within your network and authorization requests are when you're going out of network. And if you don't follow their specific rules for obtaining those authorizations for out-of-network treatment, they will deny the treatment, regardless of medical necessity. And this is extremely important when you have an HMO. Medical necessity is not enough to trump if you do not follow the procedures that are in place for obtaining the requisite authorization to receive treatment. So typically the HMOs don't cover out-of-network care unless you can demonstrate a true emergency of some sort that required you to go out of network for the care that was required. So when we're looking at HMOs, it's really important, if you're evaluating your coverage, to keep in mind that you might have a lower monthly premium, which is very enticing for many people because insurance costs continue to rise. But it's also important to balance that with the fact that your choices will be very limited, and your choices might often be dictated to you by the network that's provided in your HMO.
I just want to jump in real quick. I'm looking at the chat and wanted to answer a question. If there's no in-network provider in your area, and usually the area is considered like a 50-mile radius, the plan is required to provide you with benefits for treatment at an out-of-network provider, assuming that your plan provides mental health benefits. So it would be something like if the plan says, yeah, we provide benefits for a cardiac condition, but we have no cardiologists in network. Well, that doesn't work. You need to have the right provider for the benefit that you're getting. So, and we do see this in a lot of mental health parity situations where they're not providing the appropriate benefit for the service or treatment that's required for mental health, but they would provide it for somebody with a physical or medical, surgical ailment. So yes, they need to provide someone out of network if they don't have an in-network provider within your area.
And I'm also just going to address another question really quickly that's in the chat before we move on. It says, I have an approved single case agreement with my insurance company for my daughter's provider. However, Anthem does not cover what the provider is charging for the services and only covers Anthem's in-network level support. Do I have an argument to have them cover the full amount? Unfortunately, you don't. You have to go back and look at the single case agreement. Generally, they will only cover their in-network level of support. So if hypothetically the in-network level of support is a $30 copay and the bill from the provider is $200 per session, then Anthem is only going to reimburse you for that amount that is covered at the benefit level. They're not going to reimburse you for anything above that. It's important to review any document that you receive, if it's a single case agreement or an out-of-network exception, because they will clearly put the terms of the agreement in that letter. So you want to make sure that you review that, and it will tell you specifically what they're covering and for how long. So we will keep getting to your questions as we go through, and also circle back to them at the end, but I just saw that, so I wanted to address that really quickly.
Let me do one more because I know we have more material to cover and I don't want to get too far away from it. But there are a lot of questions about what kind of plan people have, and Carrie answered some of the questions in the chat, but essentially if you have a PPO, that just tells you that you can go to an out-of-network provider. It could be an insured plan. You could have a PPO with an ERISA plan or an individual plan or a government plan. It just is like it's just a type of benefit you might get under a plan. It doesn't really tell you whether it would be ERISA or not ERISA. And if you purchase, think of it this way. If you go online on Covered California, you buy a plan, then you're purchasing that plan that's an individual, that would fall under like an individual, not ERISA plan. If it's a plan that you're getting through your employer, then it's always going to be ERISA unless it's a government or a religious employer. But if you do go on like Covered California, if you get an ACA plan, all those terms would refer to an individual insurance policy that you're purchasing off the exchange, same sort of thing. Okay. All right. We'll go back to some more questions as they come up, but just wanted to address those.
So levels of care for mental health treatment, as an individual, if you're a patient or a family member or someone who's helping someone as a care advocate, you want to know what are the requirements from your insurance company for each level of care. You want to know what are the costs of each level of care from the provider, and does the insurance company have any rates or willing to cover, and does the plan explicitly cover each level of care, or conversely, does the plan exclude a level of care? And while they shouldn't do that, we have seen examples of cases where policies or plans exclude area and made significant headway. So these are things that, again, having your plan or policy, having a copy of it, you'll be in a better position to educate yourself or educate a family member or friend as to what they should be looking for if they have an issue with their insurance company, or if they proactively want to look at it to see if they're going to have any issues with their insurance company. Many people are familiar with the ACA, or the Affordable Care Act, and does not permit insurers to require patients to what is termed fail first at any one level of care to qualify for a higher level of care. So for example, an insurance company can't issue a denial saying, we are going to deny residential treatment for this individual because they did not first try partial hospitalization care. Or we're going to deny partial hospitalization treatment for an individual because they did not first try intensive outpatient treatment. That is illegal. We saw that historically, and fortunately with the passage of the Affordable Care Act, I can say that we've seen it less and less. It does still unfortunately slip through the cracks where an insurance company hasn't updated their guidelines or their policies. So it's not, it can still happen, but that is not legal and is something that you should bring to the insurance company's attention. When we evaluate cases and talk about mental health treatment, we're generally looking at 5 levels of care for insurance coverage. The highest level of care is inpatient care, which is for individuals who are medically or psychiatrically unstable and individuals who require 24/7 care. The next level of care below that, which is less restrictive, is residential treatment, and this is for medically stable patients or individuals who require 24/7 care, but they're medically or psychiatrically stable. Partial hospitalization treatment is treatment that is received 6 to 8 hours a day, typically 5 days per week. So an individual doesn't require 24/7 care, and they are most often traveling to and from their home or wherever they're living at that time to the treatment center. Intensive outpatient treatment is typically 3 hours a day, and it could range from 2 to 3 days per week. And again, the individual doesn't require 24/7 care, and they can travel to and from treatment. And then the lowest level of care, which has no restriction, is outpatient treatment. And this is what we equate to 45-minute or hour therapy sessions, psychiatric visits for medication management. And an individual might have outpatient therapy 1 or 2 days a week, or 3 or 4 days a week, depending on the level of care that is needed. So this varies from patient to patient. We talk about submitting timely claims next, because this is one of the key factors in navigating what is referred to here in the cartoon as the reimbursement maze, because it often does feel like you're in a maze and you might not get out, but if you're lucky, you do get out. So some of our tips and considerations that we discuss with people, again, I know we've said this over and over again, but is to review the plan or policy for any requirements or timeframes as to when claims have to be submitted. So if a claim has to be submitted within 180 days of treatment or 365 days of treatment, you need to know that, you need to be aware of that. Check if the insurer has a claim form, and if they do, then use it. Don't ignore it, and we'll give you an example of it on the next slide. We always advise people, and we even have to remind our own staff that when we're sending claims, they have to go in by certified mail or some other method for delivery confirmation. There's just no guarantee that someone's going to receive what you're sending, especially in the last 2 years, the pandemic, people working remotely, mail taking longer to get from point A to point B. So we always tell people to make sure you have receipt of mailing it and confirmation of delivery. And most importantly, keep copies of everything you send. This is something that we stress over and over to everyone. It's not enough just to send it, but you want to keep a copy of it, because even if you send it and they receive it, they might come back to you and say, we lost it, or we uploaded it and discarded it, and then we lost it. So you just always want to make sure that you have a record of everything that was submitted on your behalf or on someone else's behalf. So as I said, if the insurer has a claim form, you should use it. And here's an example of a claim form that is from Kaiser, and it is specifically called Member Reimbursement Claim Form. And I apologize, I know the text is a little shrunk and small to read, but we just wanted to give you just an example of something to set your eyes on, to show you that it very clearly tells you what you need to provide if you want to request reimbursement for services that you've paid for out of pocket. And in order for your claim to be considered for payment, you have to complete their form. You have to provide an itemized bill from the provider that shows the charges that were incurred. You have to give a payment receipt, and that could be a copy of the check or a bank or credit card statement, but some proof of payment. You also need to send all of these items, in this particular case, to a particular address. And Kaiser even tells you, which is really interesting, Kaiser even tells you to keep a copy of all the documents for your records. So if hearing it from us isn't enough, the insurance company here is even telling you to please keep your own copy. And on the next page, they tell you very specifically where to send the documents depending on where the member resides. So oftentimes we're dealing with California members, so it tells us where to submit claims for California members. It also requires signatures, so you have to make sure the right individual is signing the form. And all of this to say that even if you do everything right, they still might tell you that you didn't send it to the right place, or you forgot something that they want from you. So I highly recommend responding to them, even if you believe you did everything right and you submitted everything that they requested. Because if you don't respond to them, or you ignore their request for additional information or to send it somewhere else, it will not get reviewed. So bottom line is, do what they ask and continue to do what they ask, because otherwise you run the result of them simply ignoring the claim, or just denying it for insufficient information, or for not receiving it. So I know we've been at it for about an hour, but about an hour ago, we told you that we were going to talk about explanations of benefits and what they are, and the fact that while a denial is generally required to be provided from an insurance company within 30 days, a denial might be in the form of a letter, or it might be in the form of an EOB. And what is an underpayment of benefits? Well, an underpayment of benefits is a type of denial. If you believe that you are owed $100 and you submitted a claim to your plan or your insurer for $100, and they only pay you $10, then what is your recourse? What do you do? Well, if you want to challenge that, then you have to file an appeal. So denial letters and EOBs can both be forms of denials, and they both can be appealed. And I know I just said this, I'll just reiterate it. If the insurance company asks you for more information, and most commonly the one that we get is they want additional authorization forms, or claim numbers need to be corrected, or medical records are missing, then please provide that to them, because without that additional information, that is sufficient reason for them to deny the claim. Here's an example of an explanation of benefits. And as it says, it is not a bill. This is the insurance company's response to a claim that was submitted. And in this particular case, the facility, which is provider named Eating Recovery Center submitted claims on behalf of an individual who received a length of treatment at the residential level of care. And one of the reasons that I included this EOB is because my tip here is to review your EOBs and to review your denial letters. Insurance companies do not always get it right. So don't assume that they've gotten a denial letter or an EOB correct. In this particular EOB, the insurance company listed the place of service or the level of care as outpatient, and that was 100% incorrect. And this was something that we had to actually dispute and argue and clarify during litigation. The level of care was residential treatment and then a step down to partial hospitalization treatment. This individual never submitted claims for outpatient care. And unfortunately, the attorney on the other side was very unfamiliar with mental health claims and levels of care. So part of the litigation process was actually educating opposing counsel and also the judge, who welcomed the education about the different levels of care for mental health treatment and eating disorders.
Just to interject too, if you look at the top of this form, you'll see where it says group name, state of Kansas. So that's a governmental employer, right? But it tells you that it's an employer. Usually if it says a group, then you know that it's an ERISA or a group of employer plan provided benefits. So that's just a tip off for you, and the group number is there.
So this was again, a non-ERISA plan because it was issued through a state university. Okay,
we're going to talk about appeals next. This is where we really get to be advocates for our benefits. So let me know if you haven't gone on to Mentee up here on the top and use the code. You can do this little poll. It'd be great. We're curious as to who has submitted a claim for benefits before, hasn't, but thinks they might need to do so, and just don't have the need at this point. Great for you. A mix of people responding. So again, we have, you've submitted an appeal for health benefits in the past, you haven't, but you think you probably need to do it, or you don't have any claims right now that need to be appealed. Okay, we have some people who have submitted in the chat saying they've submitted, great. So I'm going to give you our sort of best practices. This is what we do in our office, how we submit quality appeals. And as the cartoon says, another may I, it's sort of about how you ask sometimes, the way you ask. So providers or patients can appeal. If it's a provider who's appealing on behalf of the patient, that needs to be clear. And there's really three ways that you can appeal. You can do an expedited appeal, and that is often occurring between the provider and the insurance company. Sometimes they call those peer-to-peers. You may have heard that. If you're a patient or a family member, you may have heard something about like a peer-to-peer call is happening. What does that mean? It means that two people operating at the same level in terms of they're both physicians are talking about the treatment that's being requested and are going to sort of hash it out in a phone call. And that's on an expedited basis. We talked before about the time frame for that is about 72 hours. The questions that we have that aren't always asked, but we appreciate when it's asked during that phone call, is asking the doctor for the insurance company, who do they work for? Are they on staff with the insurance company? Are they sort of a hired hand who's helping out and they work at a different company? Who's paying them to take this call? And what are their credentials and what's their experience? Sometimes you may have a doctor who gets into it, and if you ask them what their credentials are, they might say, well, this isn't really my area. Well, that's a tip off that they're not the right person for what's being asked for of them at this time. Somebody else needs to get on the phone. And you can ask for a different person. These are all things of really trying to be proactive and good advocates. Providers are very busy. They don't always have the time to vet who they're going to be talking to from the insurance company. But these are things that we get the hindsight of 2020 and looking at after the fact, that we would love to know what the doctor's credentials are, their experience, whoever is showing up for the insurance company. We do always suggest, if you're sending a written appeal, which is sort of the really best way to go about it, unless you need that expedited basis. If you're sending a written appeal, we'll talk more, but make sure you do it in writing. Somebody in the chat had asked about sending an email for plan documents. You could, say the same here. What about an email for writing an appeal letter? We work in the courts, and honestly, judges are kind of old-fashioned and may not see that an email receipt is as good as a certified mail receipt. We all know we work in emails. That's sort of our main form of correspondence these days. And before that was faxes. I think it's better than nothing, but we always prefer something through a priority mail or registered mail, something showing that it was received. And then you can, it's totally permissible. You could pick up the phone and just say, I got this denial, I'm appealing it, and these are my reasons why. The reason that we don't really suggest doing a telephone call is that you don't know what the person you're talking to is taking from that conversation. You don't know what they're recording, if anything, in writing, or if they're physically recording the conversation. And so what you're conveying may not be what they're getting at their end. But if you send it a written letter, well, it is what it is. There's no manipulating that. A phone call could be misunderstood. So here's sample language, broadly used, but sample language of what is great to see in a quality appeal. Say that you're appealing. Step one, I'm writing to appeal the denial of Jane Doe's residential treatment, or it could be outpatient treatment or inpatient treatment or whatever it is. On such and such a date, this insurance company denied benefits for her residential treatment by stating, and just say what it is that they said. They're saying it wasn't medically necessary because of whatever. And the denial's wrong. And take it on head on. She was having these behaviors, she's having these symptoms, and this is the risk to her if she does not receive this treatment now. And address the guidelines. As we talked about earlier, the insurance company has to tell you what guidelines they're using. You can find those online, you can ask for them from the insurance company, and you can say, these are the guidelines. These are all the, A, B, C, D items that are need to be met. And this is how she meets them. You can also, what we often do is challenge those guidelines. Attorneys have successfully challenged guidelines in the courts in recent years and said, particularly with Optum guidelines, and said, these guidelines, these are not the medical standard of care. You can't apply these guidelines. They're ridiculous. I would say the most common problem I see with guidelines is that they're asking for a higher acuity at a lower level of care. So that might mean something like someone who's asking for a partial hospitalization benefits or a residential treatment is being asked to show a level of acuity that would only be required in an inpatient treatment. For example, that you're at a risk of harming yourself or someone else, or they're homicidal. Something like that, if truly those were the risk factors involved, that person would need the inpatient hospitalization level of care, would not even qualify for partial. So the guidelines have to be appropriate for the medical standard of care in the community. And then enclose records. Say what you're enclosing so that it can be found later. We actually number the documents that we enclose so we can find them later when we get the record from the insurance company. Enclosed treatment records. We also really love the gold standard for us, letters of support from the providers. And I think providers really get on board with this. They have been treating this patient. They support the need for treatment, and it's their opportunity to tell the insurance company, you got it wrong. This is why this person needs this treatment. And I've been treating them. I'm the one who has the experience and knowledge. of this particular presentation and condition of this patient. So please listen up. Here's a letter. Those are really great. And then I know that it can be challenging to do all of this amongst everything else that's going on. Please remember the small details, sign the letter, date the letter, send it certified mail, send it multiple ways. If you have a fax number, if you have a email address, send it that way too. Just, you know, cover all your bases. And then just to review the tips for communicating with the insurance company in writing, as we said, we prefer in writing. Take notes of your phone calls. I love it when I talk to clients who say, yeah, I talked to so-and-so on this date, and this was the person, and this is the phone number, and this is what they said their position was. And I got their email address too. Just get as much information as you can. Take that information, but understand that the insurance companies will not be held liable for what they say over the phone. They can give you incorrect plan and policy information over the phone, and they cannot be held liable for it. They can say later, oops, this was just a customer service rep, and sorry, they told you that the benefit was covered, or that this was the address, or whatever it may be. This is why it's so essential to get a copy of your plan, because the information that you get over the phone, if you've had any experience calling an insurance company, you know you can call 3 times and get 3 different answers. And I actually do encourage that sometimes. If you don't like the first answer you get, call again. But in the end, it's that plan document that is going to control what benefits are provided and the information that you need. Send the treatment records we talked about, delivery confirmation. Let's make sure that they got there, particularly in this time of, can't even believe we're still saying the word global pandemic, but mail delivery is tricky. People are working from home. We work from home. You know, we have deliveries coming to our law office, but you don't know at a certain office if things are getting there or not. That's why it's really important to have delivery confirmation. Somebody signs for it. The U.S. mail has said, yes, this got there. Somebody's got it. As I said, if you don't get the right answer, feel free to call again. And if you are a provider, if you are not the patient, be prepared to have that authorization that you're able to speak on that person's behalf. And these authorizations, Carrie talked about it too, that they might require an authorization when you send a claim form in. They are available online. So we actually kind of keep copies of it because we know that they're going to ask for it. So we try to pull up the right authorization, send it in the first time. But you can pull up like Anthem authorization. It might say for an authorized rep, something like that. You can find those. It'll just save you a step in the process.
So a little bit earlier, both Elizabeth and I alluded to medical necessity guidelines. So we just wanted to kind of give you a heads up as to what this might look like if you're looking at it in a plan. So this is from Blue Shield plan, and it specifically says benefits are provided only for services that are medically necessary. Services that are medically necessary include only those which have been established as safe and effective, are furnished under generally accepted professional standards to treat illness, injury, or medical condition, and which, as determined by, guess who, Blue Shield, are, guess what, consistent with Blue Shield medical policy, consistent with the symptoms or diagnosis, not furnished primarily for the convenience of the patient, the attending physician, or other provider, and furnished as the most appropriate level which can be provided safely and effectively to the patient. So this is where the issue of level of care comes into play, and what does this medical necessity actually mean? And so this is just some sample language from one policy to give you an idea of what this medically necessary definition looks like. And then our job is, if we're appealing it, is to say why it's consistent with Blue Shield medical policy, why it's consistent with the symptoms or diagnoses, why it wasn't furnished for the convenience of the patient or the doctor, and why it was the most appropriate level of care. And that's what we tried to highlight very quickly in that sample appeal language. But it's important to obtain and understand the insurance company guidelines, because insurers have developed these medical policies that serve as one of the sets of guidelines for medical coverage decisions. And you have to know what they're using as their playbook. And this is their playbook. These are the rules that they're using to make decisions on the claims that they're reviewing. So the guidelines may or may not be referenced in the policy. You might have to ask for them. How do you know to ask for them? Because the policy might just have a reference to it. Our policy will utilize Blue Shield Magellan Care guidelines, or it might specifically say in the denial letter, the doctor who reviewed this claim used such and such guidelines for making the medical coverage decision. Then you need to call and ask the insurance company to provide you with a copy of those specific guidelines. Some insurance company guidelines are available on the insurance company website. So if you're not the type of person like me who doesn't want to deal with getting on the phone with an insurance company because that could take hours, then I always start with the website or a patient portal if I have access to a client's patient portal. That's always where I start my research and see if I can find it there. And if these guidelines or policies weren't enough, most insurance companies, if not all, have developed medical policies or guidelines for mental health treatment. So just by way of example, as I said earlier, Blue Shield has adopted the Magellan Care guidelines, which have been adopted by Blue Shield's mental health service advisor, which is behavioral health eating disorders. That's one example. Another example is Cigna standards and guidelines, medical necessity criteria for treatment of mental health and substance use disorders. So again, this is what the insurance company is using to make claims determinations. And this is what you want to make sure that you are obtaining for yourself or someone that you're advocating for, so that you know best how to appeal the denial of a claim for treatment.
Okay, this is just to give you timing. This is our last section, so we'll be done in a few minutes, and that leaves us a lot of time for questions. So thank you for those of you who put questions in the chat, and we'll be able to get to more of those in a few minutes. Just wanted to leave you though with what we're seeing in legal developments about mental health benefits in California. So this law, SB 855, was passed last year. It applied to plans in effect as of January 1st, 2021. So now we're a year later. Everybody should be in line with this. And it tried to address what the standards of medical necessity are. It tried to get around the problem that we have been seeing with insurance companies applying their own guidelines that didn't meet the standard of care. So I won't read all these, but this gives you an idea of how medical necessity is supposed to be taking into account more about the whole person. If you look at number 7, it's supposed to account for the unique needs of children and adolescents. I've run into cases where an insurance company had criteria, say, for an eating disorder, but it was just one criteria for an eating disorder. It applied to children, adolescents, adults. Well, there are very different needs within those age groups, so that those guidelines weren't meeting what the standard of care was. Number 1, treating underlying conditions. We really have seen this across the board. It's often that someone has multiple mental illnesses, they have underlying conditions, and the goal of treatment is not just to treat the current symptoms, but it's to treat the whole person and all the co-occurring conditions, which you see in number 2, in a coordinated manner and not a piecemeal approach. So this was a really great development for us in California. This is the newest law that's in effect coming up this summer. It is the SB 221. This is so interesting. I'm going to read it to you. It requires health insurers to provide prompt access to non-emergency mental health treatment. Patients who are undergoing a course of treatment for ongoing mental health must be able to get a follow-up appointment within 10 business days of the prior appointment. So this was trying to address the problem of people just not getting timely access to mental health care. It doesn't address an emergency situation, but really, if you are getting that you're getting regular appointments with your mental health provider. And the second bullet point here is so important. If there's a shortage of in-network providers, then the plan must arrange coverage outside the plan's contracted network. So I put something in the chat about this too, but this is now the law. This was always common sense because it makes sense, right? If you don't have a cardiologist in your network, you have to provide one that's out of the network. Now we have it in the law. So that's really terrific. I'm going to talk about parity in a minute, but I'd just love to know if there are any people here who have had benefits denied for residential treatment based on an exclusion in the plan. And if you, there is the Mentee.com up here, you can easily just go on and put a code in and put your answer in that polling through Mentee, or just give us an answer in the chat. Okay, so less people now than I think what we would have seen several years ago. We had a case several years ago that addressed whether Blue Shield could provide an exclusion for residential care in California, and we have a court decision saying they can't. Under California state parity, it required that residential care is provided because Blue Shield was providing something on par for a medical surgical condition, and the most common level of care with residential that's compared is skilled nursing. So the Mental Health Parity and Addiction Equity Act, we call it MAPIA. It's the Federal Parity Act. This is federal law that applies nationwide. It does apply in addition to state parity, so you really get the better of whichever law suits you. There are state parity laws across the country of varying degrees. What all these laws tend to do, and what the federal law does, is really require parity between mental health benefits and medical surgical benefits. Applies to almost all health plans, and it can apply to either a quantitative limitation, that's something you can quantify. I put something in the chat about if you provide only 20 days of residential treatment, then you can't provide unlimited skilled nursing. It needs to be on par in a number sense, but also qualitatively, if you have, or non-quantitative, you can't measure it that way. If you have medical necessity guidelines, are those same guidelines, the same level of guidelines being applied on the medical surgical side? We've seen cases where the medical necessity definition from the plan is all that's applied when you're talking about a medical surgical benefit. So if you go in hospitalization for a heart condition, they would only look at the plan definition and say, well, it says it needs to be within the generally accepted standards of care. You're good, we'll provide that benefit. But on the mental health side, they wouldn't apply that plan definition. They apply a whole separate litany of criteria from an outside source. Well, that doesn't seem to be on par. You need to have be equal in how you're applying medical necessity to medical claims and mental health claims. Something to note with the state laws, while the federal law will apply to whether you have an ERISA plan or you bought the plan on your own, the federal law applies. State parity laws are usually through their Department of Insurance. They're usually part of an insurance code. And that requires that you have an insured policy. So if you happen to have a self-funded plan, those state parity laws probably aren't going to apply. And again, states like California, we have a really great mental health parity law that provides something like residential treatment to be on par with the level of care provided on medical surgical. So as I said, that was near the end, and we are at the end. We have about 25 minutes to answer your questions. Let's see, I'm pulling up the chat. And so if there's anything that we didn't address, you'd love us to address here, we're happy to do so. And if we didn't get to it before, if you want to repost your question. And if you don't want to talk about it here, it's fine. I know it's been a long afternoon. We really appreciate you sticking with us and listening. It's been great for us, but our information is here and you're welcome to email us if you have a follow-up question or something really specific. We're happy to get to it that way too. Okay, so we have a question about Health Net says out-of-network office visits are covered at 50%, but telehealth has to be a preferred network. So I think the question is going to be whether this applies to just mental health benefits, or if this applies across the board for any benefits that you're getting through telehealth. I think that we're in such a changing time right now with COVID. Wow, I'm looking at claims for mental health treatment from, say a year ago that are now in litigation. And what I'm seeing is that people were not able to get into some treatment in person and were only able to do, say, a partial hospitalization by Zoom. And that kind of thing was not going to work for people. And there were really long waiting lists. There are also still long waiting lists, and all of these things complicate where we're at. I think that they also provide good argument for maybe using a different level of care that does provide in-person care if that's what's needed. So I don't have a straight answer for you here on whether it needs to be, the practitioners all need to be available telehealth. I think it's going to depend on how the plan reads.
So someone messaged me and said that the insurance company keeps denying based on the treatment not being medically necessary, even though the doctor from the facility is participating in the peer reviews and is advising that the patient requires further clinical care. And unfortunately, this is what we see happen time and time again. The insurance company likes to step in and make medical decisions about an individual's treatment when they are not the individuals who are actually in the best position to make those types of decisions or issue those kinds of opinions, and the treating doctor at the facility is the best person to do that. And this is extremely frustrating for everyone involved. It's frustrating for the facility because they don't know how to plan an individual's treatment, whether or not the individual will be able to stay or not stay. It's frustrating for the family member, or spouse, parent, sibling, or advocate, because you have to make a decision whether or not you can financially afford to keep the individual in treatment, or if they can afford to stay in treatment. And while I wish I had a better answer, all I can say is what we tell everyone, which is to keep fighting and keep appealing and keep at it, because oftentimes insurance companies really bank on individuals giving up and not challenging their decisions and going away and accepting their word as the final word. So if you have the ability to advocate, keep advocating. If you need help, reach out for help, but don't let them get away with making decisions about medical necessity.
Yeah, and a few people have mentioned Kaiser, which is its own beast. I mean, Kaiser in California is a troubling place to be if you need care for a mental illness. It's real tough. You really, what Carrie was saying about being diligent through the Kaiser system, you're going to feel like you're just repeating, the definition of insanity is doing the same thing over and over again and getting nowhere. You feel like you're getting nowhere, but with Kaiser, it's just a matter of going through every single hoop that they put in front of you. Somebody mentioned, let's say a person with bipolar 1 only gets therapy once every month to 2 months at Kaiser. Can we challenge Kaiser about this? If the person who has the bipolar 1, if their treating physician believes they only need that therapy once every month to 2 months, then it's going to be hard to challenge it. But if you have a provider who's on your side and says, you know, this is not enough, this person needs to be looked in on by a physician more often than this, then yes, I would absolutely challenge that. And if you're not happy with the answer you're getting from your Kaiser physician, speak up, tell them, say you want a second opinion. Kaiser does allow for a second opinion. And you just have to push through. I mean, it really depends for that particular circumstance. It depends on the way the person is getting by with their condition. It's such an individual, it can be such an individual presentation.
One of the issues that brings to mind is with Kaiser having a lack of availability and a shortage of practitioners. So as Elizabeth was saying, what I'll just add to that is if the therapist who's providing the bipolar 1 disorder feels that again, the patient needs to be seen more often, that treating provider needs to be the advocate to get the individual in treatment more. And if Kaiser can't provide that treatment more, that frequency of treatment more, then you need to ask that provider to support you in your request for a referral authorization. So an authorization to go out of network to see another provider who's available to provide the frequency of treatment that the patient needs. Again, I think with Kaiser, you have to keep in mind that you have to be patient because while all insurance companies work very slow, Kaiser works especially slow, and their process is set up and designed to take a long period of time.
Okay, so thank you for posting the HealthNet policy about telehealth services. So it reads that mental disorders are provided appropriately at telehealth services and telehealth covered only when performed by a preferred provider. So this would be fine as long as it says that other conditions, physical conditions, are also must be treated or can be treated at telehealth only when performed by a preferred provider. It needs to just be the same. And if there's any difference there, then that's something that isn't meeting mental health parity. And something that we didn't touch on, but you can also go to the Department of Managed Healthcare and go to the Department of Insurance. And if you feel like you're hitting a roadblock and you've got something that just seems like it's really unfair, the Department of Managed Healthcare or Department of Insurance will sometimes open investigations into insurance companies' practices. They are long, they may not necessarily get you what you're looking out of it, but it's good to put your voice out there and let them know what's happening, because sometimes the only way the DMHC and Department of Insurance knows is if they hear from patients and they hear from consumers.
So people are asking again, you know, in the case of Anthem, they have an online appeal process. Is that as good as certified mail given the digital footprint? Again, we look at it from the litigation standpoint and how to best set the case up for litigation. And as Elizabeth said, the courts and judges are still old-fashioned in the way they accept technology and the way they review technology. So if you only have access, you know, or you're only capable of doing things online, then it's better than nothing. But if you're able to do things by mail as well, and possibly by online as well, that it's certainly acceptable. We are not going to tell you it's not acceptable, because you want an appeal as opposed to no appeal.
We're sort of looking at things as the worst case scenario.
Yeah.
So just know that we're thinking like worst case scenario. If push comes to shove, do you trust the Anthem website is getting your appeal and going to keep it and preserve it forever? And if it needs to be pulled up again, everything is in there just as you presented it. So that's, you know, yeah, I have Anthem. I, you know, go online to pay for providers that way. I'm taking a leap of faith that they're going to do the right thing. I'm doing it right, you know, but an appeal is really important. And so just from the end of it that we look at, we're just trying to give you like the best possible way that this could be done. Lots of people do it other ways and it works out just fine. So. Oh, I'm so glad that somebody mentioned the NPR. They have a really great segment. They're called their Bill of the Month. If you're at all interested, go look up NPR Bill of the Month, and they go through a health insurance bill every month. And I blogged about one of them, which was so fascinating. And anyway, it walks you through pitfalls. It gives you a little bit of a deeper dive. And we've given you a few examples today, but it gives you a deeper dive into some things that can go wrong. One thing that they did a few months ago, which was their Bill of the Month, that I have filed litigation on, I've seen it, is if you have an employer provided health plan and your claims administrator changes. Your employer decides, hey, we were with Aetna last year, we're gonna go with Anthem this year. And you're like, great, okay. You had gotten a medication for 10 years that had always been paid for, not a problem. All of a sudden you have a new claims administrator and they're denying your medication. What's with that? Well, all of a sudden they have new guidelines that they may be applying. There may be new plan language that they're applying, and it can really trip you up. And so if you at all are nerds like us and interested in that kind of thing, definitely check out that NPR segment, because the strangest things happen. Oh, somebody said that happened to them. Yeah.
So someone posted a question about Anthem ignoring out-of-network provider submissions. At this point, should I file an appeal? Well, at this point, if they're ignoring your out-of-network submissions, there's nothing to appeal. You need to follow up with them and find out why they are not processing these submissions. And if there's additional information that they need to put that to you in writing and give you notification of what's happening with these submissions. And also review your policy or plan language to see what they will pay or not pay, so that you have an idea of what to expect. But sometimes people ask us, they're anxious to file an appeal, but we have to tell them to slow down and wait, because until you actually have a denial in the form of a letter or an EOB, there's nothing to appeal, and then they will keep ignoring you if you file appeals. So best to follow up with them and find out why your submissions are not being processed.
And sort of a caveat on the sending things in writing, one technique I really like is calling the insurance company and saying, so I'm confirming that you got these submissions from my out-of-network provider, that you have the claims, when are you gonna be submit? And they may say, oh yeah, we see them right here, we've got them, we're gonna process them, you'll get a response in 30 days. And then writing to the insurance company and confirming the conversation you just had with the person you spoke with and confirming that this was the case. I do this a lot because I want that to be documented in some way. I don't trust what they're documenting. I need to have it documented. If I take a case to trial, it's really great if we've done the appeal and we can look and see all the steps that we took and that the insurance company didn't respond, didn't give an answer in a timely manner. So another way that you can communicate.
Just to reiterate that all of our contact information has been put in the chat, as well as our emails, our phone numbers, web address for our firm has all been posted in the chat a couple times. The slides will be sent out, and NAMI will also let you know when the recording is available. I know several of you have indicated that you're going to locate your insurance policy and review the medical necessity guidelines, and we love hearing that. That warms our heart. If that's the only thing that you walk away from here with today, then we feel like we've done our jobs. And this was really exciting opportunity for us to give back to the community and share some of our tips and practical advice with you. And we really hope that you don't need to contact us. We hope that you don't need our services. We hope that you don't need us to consult with you, But if you do, please know that we're here and we're happy to consult with you and review any matter that you'd like us to consider. It's always our pleasure to work with NAMI and other organizations that are providing this type of education and support and policy work for individuals in the mental health world. So for us, it really is just an honor to be with you this afternoon, and we really appreciate everyone who took the time out of their busy lives to be here with us.
Yeah, thank you again, Regini and everybody at NAMI. It's been really great for us to, it's therapeutic for us to get this off our chest because we're doing this all day, every day. And the more we can empower people to handle these on their own and make the insurance companies accountable for what they're doing, it's better for everybody.
Thank you both, Elizabeth and Carrie. We really appreciate your wealth of knowledge and information on this. And Elizabeth, I heard you say you've been doing this for nearly 20 years. So and then I just I feel like this information is always needed, and especially when it comes to navigating insurance. It's really difficult for everyone. So I'm seeing a lot of positive feedback on how, and it's great. I'm thinking about, I need to go back and look at everything, review it, and get to be educated about things that directly affect our lives, and how we can work with the system. So again, I appreciate it so much. I appreciate everyone else for being here. Whoever is sharing screen, do you mind just going into the next slide? Next slide. You had it. So yeah, I just want to thank everyone. Kim just put in our the emails where you can contact Kantor and Elizabeth and Carrie, as well as please take our post-event survey that we always put in. It's, I think, the second link. What's it called? Or is it? Yeah, it's the second or third link, yeah, where we would like to see your responses on how you like the information and just any feedback that we can provide, so that we can provide more information and other related topics that could be beneficial for you all. And I just want to there's a coming up next town hall next month on March 8th on treating mental health, balancing in-person and telehealth care with Alliance for Patient Access. We're going to be talking about telehealth in that one. But again, I just want to say thank you all for joining us this afternoon. I really